Hello everyone, this is Dr. Wajid Shabir with another video on ECG. This is the ECG which we will be discussing today. But as usual, before starting the discussion on ECG, I would like you all to pause your video, note down the findings and diagnosis with yourself, and at the end of the video, compare your findings with what was discussed in this ECG. So let's begin the discussion on this ECG. As you know, the first thing which we look at on ECG is rhythm. For rhythm, we look at the rhythm strip or lead 2. In this case, the rhythm strip is at the bottom of ECG. As you know, for rhythm to be sinus, there should be upright and prominent P wave before each QRS complex. If you note down that there is no such P wave in this case, which means that the rhythm in this ECG is not sinus. It is originating from anywhere else from along the conduction pathway. After the rhythm, the next thing which we see in ECG interpretation is heart rate. There are multiple methods to calculate the heart rate, but we use a simpler methods in our video in which we select a QRS complex which lies on broad vertical line, and then we calculate the large boxes between this QRS complex and next QRS complex as 300, 150, 100, 75, 60, and 50. In this case, the second QRS complex lies between 50 and 60, and it is about the rate is about 55 beats per minute. After the heart rate, the next step in ECG interpretation is detection of axis. As you know, for axis we look at lead 1 and lead AVF. The QRS complex in lead 1 is isoelectric. That means that the R wave in lead 1 is almost equal to S wave. While in case of lead AVF, the direction of QRS complex is upwards. So as a whole, the axis is directed mainly towards lead AVF. So the axis in this case is vertical. Now, after the axis, we'll again look for rhythm, the origin of rhythm. The rhythm can originate from atria or AV junction or even ventricle. So we will mainly look at the duration of QRS complex to differentiate between ventricle or supraventricular origin of the rhythm. As you can see that the duration of QRS complex in this case is less than 3 small scales, means it is less than 120 millisecond. So this is basically a narrow QRS complex. If we look closely in rhythm strip, after each QRS complex we can find an inverted P wave. This type of inverted P wave which appears after QRS complex is called retrograde P wave. Also there is a broad QRS complex as it is underlined with axis which is different to normal QRS beats. This is basically premature ventricular contraction. So, rhythm which is for around 40 to 60 beats per minute, and in which there is narrow QRS complex followed by retrograde P wave. It means that the origin of rhythm is from AV junction. So this is junctional rhythm. Another thing which you will note that the voltage of S wave is prominent in lead V3. So as per Cornell criteria, in case of females, S wave in lead V3 plus R wave in lead AVL, that is more than 20 small scale, it stands for left ventricular hypertrophy. So in this case, the amplitude of S wave is about 22 small scale. Which also there are ST sagging, which probably means that this patient has left ventricular hypertrophy. If we focus on lead V5, we can see that the QT interval is quite prolonged. The QT interval is about 600 milliseconds along with presence of U waves. So to sum up the findings, there is junctional rhythm at about 55 beats per minute. The axis is horizontal. There is left ventricular hypertrophy and there is prolonged QT interval. So this is all for today. Hopefully you would have liked our video. For more videos, kindly subscribe to this channel and stay tuned. Allah Hafiz till next time.